Hello, my name is Antonio Rubino, and I'm going to talk to you about LV assessment and filling. This is the overview of the talk. So we start with the main views. What are the views to assess the left ventricle? How we assess the systolic function, and few measurements like fractional shortening, fractional area change. I mentioned about the Simpson biplane and how we do assess regional wall motion abnormalities, and especially how we assess ventricular filling. As we have learned, the basic views of our focus heart ultrasound are parasternal long axis view, parasternal short axis view, apical 4-chamber view, subcostal view, and with a slight rotation of the probe from a subcostal view, we can visualize the IVC. The parasternal long axis view is the view we classically start our focus ultrasound scan with. And as we learn, we put the probe on the third or fourth intercostal space, on the parasternal intercostal space, on the left side of the sternum, with the notch pointing towards 10 o'clock, with a probe almost perpendicular to the chest wall. The structures we are going to scan, starting from the top in a clockwise direction, is the right ventricular outflow tract. It's a small part, the outflow tract of the right ventricle. We are not able to assess his right ventricle in its maximum diameter, but it's actually a small portion of the right ventricle. And then underneath we see the aortic valve and the aortic root. Underneath, below the aortic valve, we can see the left atrium with the three structures almost aligned and almost with the same diameter. The main structure we see on this view is the left ventricle with its basal and its mid-cavity portion. We are never able to visualize the apex of the left ventricle in the parasternal long axis view. Other structures we do visualize in this view is the interventricular septum that divides the right ventricular outflow tract from the left ventricle, the cross-section of the descending aorta just below the left atrium, and the pericardium, which is very well seen usually on the inferolateral wall of the left ventricle. Once we have completed our assessment on the parasternal long axis view, we do move to a parasternal short axis view, simply rotating the probe from the right shoulder, moving the notch towards the left shoulder. We do stay the same intercostal space. And what we see is the left ventricle from a long section becoming a circle and getting a cross-section of the left ventricle. The left ventricle in this view is pretty dominant, is the view that is better visualized, while the right ventricle is hugging and is around the left ventricle often appears as a circle. The level we need to scan the left ventricle is the mid-cavity. So we do visualize the papillary muscle, the cross-section of the anterior and the posterior papillary muscle. This is only a cross-section of the left ventricle, but we do appreciate all the segments, starting with the anterior wall, the inferior wall, the lateral wall, and the septal wall. The apical 4-chamber view is obtained by placing the transducer in the fourth or fifth intercostal space with the orientation notch facing the patient's left shoulder somewhere between 2 or 3 o'clock. In this view, we can check, we can assess all the four chambers of the heart, with the left ventricle in all its length, from the base to the apex, and this anterolateral wall and this inferoseptal wall, the right ventricle and the left atrium and the right atrium. This is a view that gives us overall information about the heart, dimension and function, and we can actually assess the left ventricle after an initial assessment we have performed in the first two views, the parasternal long axis and short axis. To obtain the subcostal four-chamber view, we need to place the transducer just inferior to the xiphoid process, with the image notch towards the patient's left side, normally at 3 o'clock, and the sound being slightly angled anteriorly towards the left side of the chest. We do recognize the four-chamber of the heart with a slightly different orientation. And again, although the right ventricle is very well visualized in this view, the left ventricle is still the most dominant structure on this view. The LV function assessment is probably a cornerstone of echocardiography and is one of the first assessment we learn once we learn echocardiography. There are several quantitative and laborious methods which are generally part of level 2 accreditation. The aim of the level 1 of a focus heart scan is actually to assess, together with the preload assessment, have a qualitative assessment of LV function to guide our therapy. The main indication when to perform a focus ultrasound in critical care area is mainly when we face a hemodynamically unstable patient which is not responding to our current treatment, and when we have a hypotensive patient and we don't know, we can't understand whether the hypotension is due to a pump failure, whether it is due to a fluid status of the patient, or whether it's actually due to a profound vasodilation. With a focus ultrasound scan, which is performed in under 10 minutes, we need to be able to recognize what is normal from what is not normal. When we say not normal, we need to be able to recognize a left ventricular or right ventricular failure, so hence a pump failure, versus a patient which is profound hypovolemic or vasodilated. The finding we need to get with assessing the left ventricular function is actually to assess whether the function is normal or is bad. It's very often a binary finding. To assess the left ventricular function, we are going to perform a visual assessment, a qualitative assessment, which is usually fast and the most practical assessment. And we need to assess is the heart, the left ventricular, the left ventricle in at least two views, and assess carefully between systole and diastole to have more of a precise idea of its dimension and function. A left ventricle, a normal, a left ventricle with a normal systolic function, we should have the left ventricular walls moving vigorously towards the center of the chamber. The LV wall should thicken as the muscle contracts, and all the walls should move equally towards the center. We can see on this view a normal looking left ventricle. This is the parasternal long axis view, where we visualize the basal and part of the mid cavity of the left ventricle. We can see the interventricular septum and the inferolateral wall of the left ventricle. We can appreciate how the walls are thickening in systole and the difference between thickness of the walls in between systole and diastole. We also can appreciate how the walls are moving towards the center. We can definitely realize the difference in the internal dimension of the left ventricle between systole and diastole. The overall judgment is of a left ventricle which is moving vigorously and is moving synchronously towards the center of the cavity. We can perform a similar judgment on the parasternal short axis view. On this view, we have a left ventricle which is pretty dominant in this view, well visualized. Although we visualize only a slice of the heart, actually we can appreciate all the 6 segments in this view, with the anterior portion on the superior part of the screen, the inferior segment, the lateral segment, and the septal segment. It is good to orientate yourself in understanding what is anterior and inferior from what is lateral and what is septal. And same judgment, we assess the thickening of the walls, whether they are thickening all together at the same time, and whether the walls are moving towards the center of the screen or the center of the LV cavity at the same time. We should look at the ECG, and we should probably recognize the systolic and the diastolic phase. In the apical 4-chamber view, we can see the 4 chambers of the heart with a left ventricle which is again dominant in our view. We can appreciate the left ventricle in its length from its base up to the apex. We can see the anterolateral wall and the inferoseptal wall. Similar judgment, we should check the walls. We need to check whether they are thickening all together and whether they are moving all together towards the center of the cavity. In this view, we should also appreciate the basal part of the ventricle, of the left ventricle, moving towards the apex, and the apex contracting as well and changing its dimension between systole and diastole. It's our overall judgment that we do on the left ventricle, and we should clearly see a difference between systole and diastole. The subcostal 4-chamber view, the left ventricle, although is the dominant structure in this view, the resolution might not be as good as the right ventricle in this view. But we should have a similar judgment and a similar assessment that we have had in the previous view, in the apical 4-chamber view, with a basal part of the left ventricle moving towards the apex and the synchronous movement of the walls, the left ventricular walls, towards the center of the cavity. We can appreciate in this view an extreme. We can see definitely a poor left ventricular function. This is a parasternal long axis view. We can, starting from the dimension, we can check, we can clearly recognize a dilated left ventricle, and we can see how the walls, the left ventricular walls, the interventricular septum and the inferolateral wall are not thickening, and there is not much of a difference between systole and diastole. There is also not much difference of internal dimension between systole and diastole, with a movement of the walls which is almost pretty similar between systole and diastole. The same poor functioning heart could be appreciated in this parasternal short axis view. We can clearly see increased internal dimension, a lack of thickening in systole in all the segments, and a small difference in internal dimension between systole and diastole. It is easily graded as a poor functioning heart, and although it's difficult probably to gather the specific regional wall motion abnormalities, we can appreciate that the inferior portion of the left ventricle is moving slightly better than the anterior portion. So if we could recognize that there is regional wall motion abnormalities, although we are not required to score the each single segment of the left ventricle. In this apical four-chamber view, we can see, again, we can confirm dilated internal dimension, dilated left ventricle. We can confirm a poor functioning heart with a minimal excursion between systole and diastole, result of a poor contraction. regional wall motion abnormalities, it can be an advanced feature of a cardiac ultrasound. If what we need to assess on a focus ultrasound is to check whether there is a presence of regional wall motion abnormalities. And the best way to do that is to, as we said, to assess the left ventricle in the parasternal short axis view and checking whether the wall are thickening and moving all together towards the center in systole. Once assessed the LV function and checked whether the function is normal or is not normal, we move towards LV assessment, LV feeling assessment, and we need to recognize within the 3 volume states whether we have again a normal LV feeling, whether we have a possible patient, a vasodilated patient, or whether actually we have an underfilled patient with an underfilled ventricle. This should be one of the main features of the focus ultrasound assessment. So assessing whether there is actually the problem is in the pump, so whether there is a heart failure, pump failure, whether actually there is nothing wrong with the heart and the problem is actually into the filling status of the patient, because we have a vasodilated patient, or actually whether we have a patient that is quite behind with fluids. For your reference, we are assessing again the left ventricle. We are restarting with a normal, looking like a ventricle, left ventricle in long axis view. An underfilled left ventricle is a ventricle where we can see a vigorous movement of all the segments towards the center. We can see that the end diastolic volume is pretty minimal, and actually we can see what we normally call, or we commonly call, the kissing of the papillary muscles, or kissings of the walls, where the papillary muscles are almost touching all together each other. It is usually heart that appears as well apidynamic. While it could be easy to recognize a pump failure, a left ventricular dysfunction versus an underfilled patient, sometimes it's more difficult to recognize an underfilled left ventricle, an hypovolemic patient, compared to a vasodilated patient. Clearly, the clinical findings can help us in recognizing hypovolemic, vasoconstricted, cold patients compared to a vasodilated and peripherally warm patient. But from an echo perspective, the difference can be probably quite fine and difficult, but there is a specific characteristic that can differentiate the two patients are hypovolemic compared to a vasodilated patient. And although they usually have end diastolic and systolic dimension, which is pretty small, with both of the features having kissing of the papillary muscle, the difference usually stays in the end diastolic diameters or in the end diastolic dimensions. While a patient underfilled And hypovolemic is a patient that has both the end systolic and then diastolic diameter reduced. The patient that is vasodilated, there's actually nothing wrong with the end diastolic dimension, with an end diastolic diameter which is often normal. Just to conclude this lecture, so few tips and a few pitfalls to be aware of. The practice will make you better, will make your skills and your eyes better, and there's nothing wrong in starting with normal heart and to understand, to adjust your eyes to what is normal, and then you will easily understand and pick up and recognize the abnormal heart and the impaired, severe impaired ventricles. You need to scan systematically. There is clearly a learning curve, and the more scan, the regular scan will make your skills better. Always remember to improve the quality of your scan, adjusting depth and gain, and always be aware it's challenging to scan on in intensive care. It all depends, and more challenges with different body habitus, with hyperinflated lungs, and positively ventilated patients, and clearly with patients with chest drain or distended abdomen for some of the views. Always consider the clinical context. Always trigger your scan should be triggered by a clinical questions, and it should guide your therapy and should actually guide your management.